Our next talk will be by my friend and colleague, Dr. Tremarchi, who has already spoken to us here at this meeting and will talk to us about biomarkers in thoracic aortic aneurysm disease. Santi.
Thank you, Dr. Eleftheriadis. Thank you so much, Dr. Uwe Bashir, for the very kind invitation. Although I don't know if I'm the right person in the right moment today. Nevertheless, I will try to do my best on talking about biomarkers. Why biomarkers? This is really I'm a surgeon, so it's a surgeon point of view why biomarkers can be useful for us. They need to have a role, as I will see to show you. As we all know, chronic aortic disease, in particular aneurysms, are often asymptomatic, and the most important complication occur just in these asymptomatic patients. This has been very clear both for the ascending aneurysm and descending aneurysm has been reported in an extensive way in the last ACC/AHA guidelines, as well in the most recent European cardiology guidelines. And of course, for both type of guidelines, the threshold for treating such patients is in a relevant way lower for those affected by connective tissue disorders. In these patients, we know that we can treat these patients when they have some kind of diameter, but most of the time in our outpatients clinic, we can face with other type of lesions, and sometimes we really don't know if we have to treat or not such patients because, for example, their aortic diameter is not very high. In addition, we know that from the IRAD registry that 40% of the patients affected by type A dissection may have the acute onset of symptoms when the aortic diameter is lower than 5 centimeters. And in the IRA registry, we are able only to capture the already dissected aortic diameter. So it means that probably they have 4.2, 4.5 centimeter. And this has been observed both for the type A, but also for type B, when you can see that the mean aortic diameter of this patient was 4.1 centimeter. In addition, only for the type B patient, we also observed that 1/5 of these patients have and present with an aortic diameter lower than 3.5 centimeters. So means that before the acute symptoms, probably their aorta was 2.8, 2.7 centimeter, means almost and completely normal aorta. But as Dr. Milevich said, probably they might be younger, they might have some mutations that we don't know. The only thing that I want to report about the previous data, IRA data, is that these patients were not affected by Marfan syndrome or bicuspid aortic valve disease. So aortic diameter is not the only useful variable for predicting an acute dissection, and this is one of the reasons why we need to know more about the biomarkers. If we move from the chronic setting to the acute setting, we all know that usually the interval time between the confirmed diagnosis of the dissection to surgery is very short. But this is not observed in the registry, at least if we consider the interval time between onset of symptoms and surgery. And this is because some symptoms may be present at that time. Patients may be affected, for example, by congestive air failure or had previous cardiac surgery. So in this setting, there is a longer interval time between onset of symptoms and diagnosis. Or some others may have absence of some symptoms, like, for example, they may have absence of abrupt pain onset. So also for the acute setting, there is often a delay in doing diagnosis and also the necessity to have to know more about biomarkers. Which biomarkers? Actually, there are many biomarkers that has been reported in the literature. We'll try to report briefly something about the most common. In particular, the D-dimer. The D-dimer clearly is able to distinguish acute dissection from acute MI. It rises early, he is able to reflect the extent of the dissection. He is also able to predict the mortality. IRAD registry did a study on this type of biomarkers. D-dimer also, in these cases, showed favorable performance compared to other chest pain, in particular with the angina, patient presenting with angina. D-dimer, as the previous study, was very useful to rule out patients affected by aortic dissection in this setting. But this study also showed that the presence of this type of level, 1500 nanogram per milliliter, within 6 hours from onset symptom was able to rule in patients affected by type A dissection. D-dimer was also reported and studied in another recent paper, and also the group from Dr. Lemaire in Houston showed the high level of sensitivity of D-dimer in this patient, also for those who had a diagnosis over the 10 days period after the onset of the symptoms. So actually, if we want to report something more specific and say something useful about the D-dimer can be used for doing diagnosis of acute aortic dissection. And this has been also reported by the last ACC guidelines in this slide, as I can show here. Another biomarker that I would like to point out is the calponin. Calponin looks like the counterpart of the troponin for aortic disease, and come from a previous study basically conducted by Dr. Suzuki in Tokyo and now in Leicester about the smooth muscle myosin heavy chain due to the damaged aorta after the dissection. The fact that this change have an washout usually within 6 hours from the onset of the symptoms, so smooth muscle myosin heavy chain were not useful for doing this diagnosis of dissection after this time. But the calponin, in particular the basic calponin, was able to show the superior performance within the 6 hours, but most importantly, was able to be detected after a more delayed presentation, for example, after 12 hours and also after 1 day. So if we want to say something useful, say something about the usefulness of the calponin might be used for doing diagnosis of acute dissection, but at present is not available on the market. We recently tried to summarize this with Dr. Eleftheriadis in terms of presence of such biomarkers within the blood flow in order to understand which biomarkers might be useful for doing diagnosis in the acute setting and which not. Other biomarker might be the TGF-beta. I cannot say anything more about the previous speaker, Dr. Cameron and Dr. Milewicz, but mutation, as you saw in the previous report, has been already considered by the guidelines for doing an indication for treating surgical this patient at a lower threshold. This was already reported in terms of the phenotype of such patient, but it was very impressive, in particular that 98% of these patients with such Loeys disk syndrome present with aortic root aneurysm at this paper that was published by Dr. Cameron and Milewicz on New England Journal in 2006. TGF-beta has been also reported in Marfan. We saw that FB1 mutation may lead to an aberrant regulation of TGF-B signaling, and Dr. Milewicz mentioned about Marfan type 2, are those patients with no defect in FB1 gene. Also, these patients may have a mutation related to TGF-beta. And we, as a group in Milan with Dr. Suzuki, did a very brief evaluation on TGF-beta in type A dissection patients, and we noted that the circulating level of TGF-beta are 5-fold elevated as compared to normal controls, a little bit more present in type A compared to type B. Usefulness of TGF-beta, yes, it's useful for predict aortic growth, rupture, and dissection, and is already available. AC angiotensin converting enzyme role in aortic dissection. This has been reported as well as a potential biomarker. It has been shown that AC inhibitors prevent aortic expansion, but the mechanism is not clear. Nevertheless, it's higher in those patients affected by thoracic aortic dissection compared to control patients. Another very important point is the 41 gene signature in peripheral blood cells that Dr. Eleftheriadis widely mentioned before. It is able to detect TAA disease with an accuracy about 72 to 80% of the patients. Real-time data analysis with the kind of immediate reflex application. It might be useful for doing diagnosis of aneurysm, but at present is not available in the market. MMPs. These enzymes that are zinc enzymes, you all know, has been shown to be much more frequent in those patients affected by aneurysm, in particular MP1, 2, 3, and 9, because they determine and favorite collagen degradation. We were able to report as this level of MMPs were statistically higher in those patients treated with AAA, with abdominal aneurysm, treated with EVAR. So serum MMP levels was able to predict a kind of endovascular failure of aortic abdominal aneurysm treated in this way. And we are also able to check the role of MMPs in acute dissection, and we saw that MMPs usually increase during the subacute phase after a couple of weeks from the onset of the symptoms. So usefulness is not completely clear about the MMPs in the setting of a regular study of the aneurysm, but might be useful as a marker for detecting failure of TIVAR and EVAR, and this is already available on the market. Other potential biomarkers for abdominal aneurysm that has been reported in the literature are some proteins involved in the kallikrein system. Serum elastin peptide is associated too with the AAA expansion rate, and these are also being able to give us a kind of therapeutic targets for these patients affected by aneurysm. It has been reported that long-term doxycycline is more effective than atenolol, for example, for preventing thoracic aneurysm in Marfan patients. It has been already reported by Dr. Milevich, this very important trial on the role of losartan versus atenolol, and the losartan there is no significant difference in the rate of aortic root dilatation in young patients affected by Marfan syndrome. And another important target to us seems this paper from Dr. Ninaber and the Liegi group about the role of inflammation in the thrombus in those patients affected by post-dissecting chronic aneurysm. And you can see here the role of the inflammation and the treatment after stent graft that has been associated with an mutation, change in the plasma concentration of some biomarkers of the platelets and fibrinolysis. So this might be another potential target patient. So in conclusion, about biomarkers in aortic disease, several biochemical markers potentially might be useful for our daily purpose. This could lead to further improvements for doing diagnosis in the acute setting, but also for following our patient in the chronic setting, when they come to us just to show us, to tell us how is going on with my aorta. And we always go forward with a new CT scan or MRI. We might have room for biomarker if this might be used in a very extensive way, in a more specific way. Of course, these biomarkers might highlight potential targets for therapeutic intervention, as I tried to tell you. But also this might be important to have in mind that a standardized blood-based test capable of detecting individual at risk for aortic aneurysm would be very important. At this point, we don't know so much, we have to say, but the current knowledge is expanding at a rapid rate. And probably also the future for biomarkers is promising. Thank you very much for the attention.